Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope. Nothing said on the Low Carb MD podcast is medical advice. Please consult your own doctor before making any lifestyle changes.
Okay, guys, welcome. Let's see if you're joining in on social, if you're joining in on the Tro and Health app, if you're joining on YouTube. Thanks for joining us. It is 7:11 in the morning, and we are here to talk about hormones. Why are we having a special podcast and a special sort of live? And why are we, sort of streaming to the people in Tro and Health app live? Well, there was an interesting events this past week. There was a conference held, a joint conference by the FDA and the HHS with Robert F. Kennedy Jr. and Dr. Marty Makary, who are the heads of the the FDA and the HHS respectively. And they had a conference that was really interesting. And in my entire history of being a doctor, I have not, and being involved in healthcare, this is over decades being involved in healthcare, I have never once seen a public health authority come out and say, oops, we got it wrong. Oops, we got it wrong. And the topic about oops, we got it wrong, it was about hormonal replacement therapy. And this is something that both myself, Dr. Tro and Dr. Laura Buchanan will do our brief introductions. If you don't know who we are, we'll talk about. But this is something we've both been passionate about, and I think Dr. Laura has been a lot more passionate than I have. She's really led the front here at Tro and Health with our hormonal optimization program and evidence-based hormonal replacement treatment. So before we get into HRT and before we get into the news, and I'm going to pepper Dr. Laura Buchanan with tons of questions. We'll do quick introductions. I'm Dr. Tro. I'm a board-certified internist, board-certified obesity medicine doctor. I have been practicing in an insurance-free environment. I don't take insurance companies' checks for the past, 7 or 8 years. I work at a nationwide metabolic practice called Tro and Health. I publish studies on nutrition with the help of Dr. Laura Buchanan and so many others, collaborators who have worked with us. And I am passionate about getting people to lose weight, break their yo-yo cycles, get off the drugs they don't need. This is what drives me in the morning. You're joining us on the live through social or maybe in the app, and that's my other hobby. I'm a social media antagonizer. Sometimes I win, sometimes I lose, and it's just the way it goes. So Dr. Laura, do you mind doing an introduction for yourself?
Absolutely. Glad to be here. So I'm Laura Buchanan. I'm board certified in family and obesity medicine. I serve on the board of the Society of Metabolic Health Practitioners, as well as a certified metabolic health practitioner, and also a menopause society certified practitioner. And like Tro mentioned, I'm very passionate about metabolic health, helping people change their lifestyle to improve their metabolic health, get off of unneeded medications. And if you've heard other podcasts, I talk about deprescribing is one of my favorite things to do. Although when it comes to menopause hormone therapy, I'll actually say I enjoy prescribing those medications because I see what a huge impact it can have on women's lives. And there's actually one study, I'm jumping straight into it, but it was so amazing. It was a survey of over 4,000 women that had started hormone therapy, and 55% said it gave them their lives back. And that's a pretty profound statistic, and that some kind of medication could actually do that. Most people can't say that about medicines.
I want to talk about start ground level about sort of how we approach medicine, and then maybe we can just sort of go into HRT. one of the things that I know you and I have talked about this, what does it take to be a good medical team, right? It's not incredibly difficult. We have cardiovascular disease prevention, right, which should be a huge focus of every practice. And that includes focusing on metabolic health, which is probably the one ignored part of that. We have, cancer prevention. Every practice should be looking at cancer prevention and dementia prevention. And then I think we have, other things like mobility, strength, flexibility. That would be a third pillar. And then the fourth pillar would be, quality of life, right? Which includes sexual health, which includes mental health, which includes sort of, aches, pains, which includes spiritual health. And I think doctors lose sight of that sometimes. They're used to sort of, hearing somebody say, well, I have a sore throat and a fever and but there's pus coming out of my tonsil, right? Take an antibiotic. But I don't think, and I'm going to be honest, I sometimes think they gaslight patients, and I've seen this, as a doctor who has trained residents, medical students, and worked in large hospital settings, particularly when women come in with complaints of like, I have brain fog, I have, I don't feel myself, my sexual health, my sexual drive is gone, right? I don't think that, I feel like, doctors take the clipboard out and they just say, that's great, I'll see you in 6 months. So maybe you can tell us how you feel about how the average doc approaches perimenopausal, postmenopausal symptoms, the current state of affairs, and what an ideal sort of, how you practice medicine. Maybe you could describe how you practice evidence-based, women's health in our clinic.
Yeah, for sure. So I think off the bat, you can imagine many doctor's visits, maybe most doctor visits are maybe 10 to 15-minute appointments. And if someone's coming to you and says, hey, I really don't feel like myself anymore. I've got brain fog. I'm starting to get these headaches. My libido has just been demolished. And, I'm also getting like urinary symptoms. And the doctor in 10 minutes is not going to be able to adequately address those things. And so it's actually common, you'll hear people get referred, oh, you're having new headaches and you're 50, you got to go see a neurologist, or let's get an MRI, or you're having brain fog, we'll get some blood work and see what's going on. And so they don't even think to piece, all of those symptoms are actually all coming from the decrease in hormones during that time. And so most of the time when women, they're going to see their doc and they have these symptoms, they're not getting offered hormones. And if they also mention, by the way, I'm feeling more depressed or anxious than I used to, and then they're getting put on an antidepressant instead of, again, being, this is likely hormone related. You're 50, you're having all this constellation of symptoms. And there's studies showing that hormones actually do reverse that, the depression that may accompany perimenopause or the menopausal transition. And so I think that the current medical system is not set up adequately to help women, unfortunately. The other reality is with the WHI findings, the black box warning that we'll jump into a little bit later, that there's just been basically 20 years of inadequate education for doctors. And there's a study that went out looking at OBGYN residents, family medicine, internal medicine residents, and only 7% said that they felt adequately trained to treat menopausal women for their symptoms. 35% said if a woman had no contraindications to hormone therapy, that they would put them on hormones. They said they would not use hormones if they had zero contraindications to hormone therapy, and they were coming to them with classic symptoms of menopause, such as hot flashes or night sweats. And so some of that is just crazy. 7% feel adequately trained, 35% not even going to consider hormones for the most classic symptom of menopause that people hear about.
I want to talk about that because, can you give everybody a backstory? Like, excuse my, I'm in the morning, so it's a little bit I'm jumping around here, but let's come back because there's a point here to get gaslighting, which I think, you haven't really said. Like, the version of medical gaslighting is unbelievable. We have an FDA-approved product for hot flashes. It's basically an antidepressant. The mainstay of treatment is, oh, you're perimenopausal. Take a depressant. You have a mental health disorder. Take this drug for mental health because you are having these physiologic changes happen. So the degree of gaslighting that we have, I think, is absolutely, it's just crazy, right? It doesn't make sense. And you have to understand, it has to be systemic gaslighting to take these products that are antidepressants, run them through phase 2 and phase 3 clinical trials, and then go out and teach doctors, hey, you should be using this, this antidepressant for perimenopausal, postmenopausal women with hot flashes. So I don't think
to add to the hurt there,
that it's really much worse. I think the gaslighting is much worse, and you could tell. I mean, it's a miserable time, and nobody has support.
I've been told by so many patients now at this point that their other docs said they shouldn't be on hormones or because of safety concerns, mostly cited from the WHI, or that, well, this is only going to be a few years of your life, just tough it out and then you'll feel like yourself again in a couple years. And you can imagine you're a mom, you're working a job, you're 50, you're in the middle of your job, and maybe you're giving a presentation. All of a sudden you are hit with a hot flash, which a hot flash, for people to understand a little bit more, that's not just all of a sudden you feel a flash of heat. No, a hot flash, you can actually start, some women will sweat profusely. They may get a sense of feeling doom, almost like a panic attack. They can start having palpitations. There can be senses of anxiety, mood changes that can occur with a hot flash. And again, they don't necessarily last a flash, a second. They can last many, many seconds and even minutes long. So how could you continue giving a presentation if you are being hit with a hot flash, which is coming at a random point in time when you don't know it's going to come? I mean, you can just see what a terrible, horrible impact that could have on someone's life. And your doc, you go to see them, says, tough it out, it'll be okay. Or I'll give you an antidepressant.
Yeah, I think there's two problems, right? Is the problems go deeper, and maybe you tell me, I don't know if I'm going too deep, we can pull it back out. We're talking about HRT, and there was big news from the government where they said, oops, we got it wrong, and maybe HRT is something we should be considering. And so we've been talking about how for years women who've been suffering with perimenopausal, postmenopausal symptoms have been gaslit, and it's a really significant issue. I think another part of the problem is the amount of time. Maybe can you talk about how many different types of symptoms somebody can present with? Because this is something you've taught me. I think the things that come really easy to most docs to understand are hot flashes. To some extent, I think one of the things that can happen, vaginal dryness, really low libido, I think is another one that people understand, sleep disturbance. But can you talk about the myriad of symptoms in the perimenopausal phase and the postmenopausal phase that, maybe there's somebody listening out there who hears, who's hearing this and has those symptoms and doesn't even know because, like you said, they've had less than 7 minutes with a doctor in a year.
Yeah. So off the bat, about 80% of women will have symptoms during the menopausal transition. And depending on which study you look at, the average duration, somewhere between 4 to 10 years, and hot flashes on average 7 years, although about a third of women will actually have them greater than 10 years. Many women over 20 years will continue to have hot flashes. And So again, that's probably the most recognized symptom, but it can cause palpitations, and that is extremely common. And you'll hear that time and again, actually. Sleep problems is another huge issue, and that's not just from night sweats, which night sweats, I've had patients tell me, I literally have drenched my sheets. I have to get out of bed. I have to change my sheets. I have to shower, and then I have to get back in bed. And that might be happening at midnight, again at 3 a.m. So you can imagine how disrupting that could be. Even if it's not to that extent, there's just frequent nighttime waking up. And sometimes, and there's actually studies showing this, women will use alcohol to help themselves fall asleep because they can no longer fall asleep. But that is just kind of feeding that cycle, because although you may fall asleep with the alcohol, you're further impacting the quality, making that quality of sleep worse. Mood symptoms, irritability, depression, anxiety, mood swings. I've had so many people say, my husband did this thing and like that shouldn't have bothered me, and I just snapped at him for no reason. And they don't want to do that. That's just, again, that's the hormone fluctuations doing that. Cognitive changes, brain fog are extremely common. Over 60% of women report this as a symptom. Difficulty concentrating. And again, maybe you're in the top, like one of the biggest moments in your career at this point, and you're dealing with significant brain fog. And you're trying to create a presentation in your PowerPoint. So that's huge. Skin and hair changes, dryness everywhere, not just vaginal dryness, but the whole body. Physical and mental exhaustion. Just you hear that phrase, like, I just don't feel like myself anymore. Sexual problems, which the decreased libido is just one aspect of that. Genitourinary symptoms. So a lot of urinary symptoms. We can talk about the genitourinary syndrome of menopause if there's time later, but a lot of different urinary symptoms, vaginal symptoms, itching, pain. And someone once described it to me as, imagine you're walking around all day and you just know your elbow's there. You're just like constantly reminded by an annoying itch on your elbow, except now imagine that in your private area. So that can be so uncomfortable. Headaches, another common one. And then more recently, that's being recognized as the musculoskeletal syndrome of menopause. And initially, it was thought 50% of women. Now it's at probably over 70% of women start having joint and muscle pains. And 20% say this is the worst symptom they actually experience. They wake up, they get out of bed, and all of a sudden their joints hurt like they've never hurt before. And then weight gain is another one. You see a change in body composition where you start actually getting more visceral fat and decreased lean mass during this time because of that loss of estrogen.
And then they go to a doctor who doesn't ask each of these domains, basically, right? Yeah. And then they get an antidepressant because the doctor's like, okay, this is a sad time of life, right? Like, let's just give them an antidepressant. I mean, it's unfortunate, I wanted to know, you've been talking to me about this for, like, we have a full-on program now at Tro and Health. We have certainly a course coming out and imminently, and you've been lecturing on this. You've been educating us on it, and particularly how to do this in an evidence-based fashion, right? But before we sort of go down that path, like, can you talk about how hormones were treated maybe 20 years ago? How they were treated, sort of the post-WHI, which is the Women's Health Initiative, and then maybe talk about how, because we've seen the pendulum sort of swing so many ways here, and then talk about how you approach it in your practice, because I think the way you approach it is truly evidence-based. Looking at symptoms for feedback. I think it's quite unique, and that I think your approach should be a standard of care. So can you just maybe give the listener an idea of what we're talking about, in terms of how the practice of medicine has changed?
Yeah. So before the WHI came out in the early 2000s, 2002, about 90% of women without a uterus were actually on estrogen, hormone therapy. And if you look at all women, including those with uterus, about over 35% of women were on hormone therapy. Depending on the study, again, 40% of women were on hormone therapy. After the WHI came out, and to this day, that dropped precipitously, and now less than 5% of women are on hormone therapy. So that is an enormous change in practice patterns, clearly, to go from, again, 40%, 90% without a uterus, down to less than 5% with our current data in 2020. So that is, again, obviously a huge problem. We can talk about some of the statistics and issues with that. But one of the biggest things, again, is the quality of life. It was estimated 50 to 70 million women were denied hormone therapy or never discussed hormone therapy. Even if they chose to not go on it, they never had that discussion in the past 20 years following the WHI release. And so when I have a visit for hormone therapy, typically I want it to be, I want to have an hour available because, one, we've got to talk about the WHI. We have to talk about the data that came out, the scary statistic of a 25% increased risk in breast cancer, talk about what that risk really was and the flaws of the study, the types of hormones used in the study that we really no longer use. I would never use in my practice. I know there are some docs that will still use the older synthetic versions, but so I want plenty of time to explain the fears surrounding hormones, explain when you get that, although now thankfully I won't have to do this part. I used to explain, hey, there's going to be a black box that tells you you're at risk of all these terrible things. You're not really at that risk when you are starting these hormones I'm about to prescribe you. So we would need, again, ample time to go over all of those things. Also, before the visit, I would send them something called the menopause rating scale, which goes over 11 different categories and measures severity from none to extremely severe. And that way, when they're coming to see me, I know what is really bothering them. And that can help me target my therapy a little bit more, my recommendations, and then also just guide the discussion. Because again, if someone's having sleep problems that are really severe, it's not just hormone therapy I'm thinking about. I'm thinking about sleep hygiene, and I'm thinking about dietary patterns. Are they eating right before bed? So there's other things that's going to help guide. But I think it's really important to know all of the different ways that they are potentially being impacted by the hormone changes. And it's a great way to educate because, again, like you mentioned, Tro, people are not aware because they have not been educated. These new joint pains are actually associated with the hormone fluctuations. They think, I'm just getting older. Or, again, the vaginal symptoms, unfortunately, a lot of people have been told that's just what happens with age. You got to deal with it. And that is absolutely not true. There are amazing treatments for it, so you should not have to deal with any symptoms like that. So again, I think it's a really great starting point for a conversation. And then maybe I stop there, or I can tell you kind of my follow-ups.
Yeah, well, let's pause right here. So tell me if I got this wrong. Basically, and I know this space a little bit. You go back and a lot of synthetic hormones, maybe standard approach, and then this is 2 decades ago. Again, for the listener, we're talking about HRT and how this has progressed over the past 2 decades. Then comes this bombshell Women's Health Initiative, which sort of shakes up the world and says, maybe there's harms to this, right? But when they reanalyzed it and they looked at other studies, it was really just egregious use in geriatric populations. Interrupt me if I'm saying something wrong, right?
And so I think it wasn't even a part of it 100% was the fact that the average age in the study was 63. So these women were more than 10 years postmenopausal, and there are numerous studies now showing that you do not get the same cardiovascular prevention benefits, potentially dementia decreased risk benefits, or all-cause mortality benefits, actually. You do not get those benefits if you start the hormones over 10 years after menopause or over the age of 60. And so this study took asymptomatic women with an average age of 63 and put them on these synthetic horse urine, Premarin, conjugated equine estrogens and medroxyprogesterone acetate, a synthetic progestin.
Yeah, it's and I think that's where the fear came from, right? That's where the fear came from, and there was a huge shift, right, at that point. And I remember that point. I remember the Women's Health Initiative coming out, and I remember, if you look at the space, like it was $1 billion industry for pharma that was just crushed in basically a day. So I remember this clip pretty clearly. And then, over the last 10 years or so, I've seen some egregious, because women have been really gaslit, excuse my language, and because perimenopausal, postmenopausal women have been gaslit by their doctors. Doctors had no options. The drug companies hadn't run the FDA trials to use their antidepressants for this, right? Women had really nothing. And so women who knew there was something wrong sort of turned to alt medicine, right? And I've seen the other side of HRT, not the way, I'm so impressed by the way you practice, minimal dose, frequent tracking of symptoms, making sure that we're sort of dosing it appropriately.
And I wouldn't, I might use it, instead of saying minimal dose, I would say an appropriate dose.
Yeah, minimally effective dose though, right?
Not even minimally effective. So yeah. There's studies showing in bone density that if your estradiol levels are actually 50 to 60, that you may actually get more improvements in bone density compared to if your blood level is only 20. And there's a huge spectrum on how much estrogen women actually absorb, say, from the transdermal estradiol patches or the creams. And so although it's not necessarily recommended to watch hormone levels, I think it can be very helpful to actually look at women's hormone levels and say someone is like, wow, my hot flashes are gone, but we check their level and it's 30, we may go up on the dose a little bit and say, you could get additional benefits from a bone density perspective if your estradiol is higher than 30. And so, we'll monitor for any negative side effects, but there's definitely times I think you actually do get probably a little bit more benefit. There's a study on women who have osteoporosis that were postmenopausal women with osteoporosis given transdermal estradiol 0.1 patch, which is the highest patch out there, versus placebo, and they had only 8 fractures in the intervention arm compared to 20 fractures in the placebo arm over the course of a year. So that's a similar risk reduction to the bisphosphonates. So, I don't know if there would have been the same magnitude of benefit had they used a 0.5 or a 0.25 patch. So I think this is another area that I'm really hoping, now that the FDA has gotten rid of this black box warning, it's going to open up a new time of research where we can get more blood work levels of hormones to figure out what is optimal. Is there an optimal level of estradiol for benefits from a cardiovascular, dementia, more on bone density and mortality?
Well, let me give me a chance to maybe clarify my statement. What I saw happen in the last 15 years post WHI has been women have been finding sort of alt docs, who understood that HRT had benefit. We're trying to find, really, convenient ways to maybe give hormonal replacement, and then, potentially using pellets. And I think we've talked about this, where I'll tell you the good part about those pellets is, a lot of times docs would finally say, you know what, maybe we should even be thinking about testosterone replacement, right? Which that's the good side of it, right? The I think the female dose, and you can tell me if I'm wrong, is about 1/10 the male dose, particularly if the if the perimenopausal, postmenopausal sexual drive is really down. This is something you consider. And if I'm saying something wrong, just interrupt me. Laura, because you're the expert. Um,
That's the
but what
typical
we saw,
thing.
what we saw is, and we've seen this even in our clinic, where sometimes the testosterone would be dosed to a level of 300 or 400 using these pellets. So we saw the complete other end, which is we were so happy to see docs embracing HRT and saying, wait a second, this is something that can help perimenopausal, postmenopausal women. There was a guideline on testosterone maybe 7 or 8 years ago saying, hey, docs should consider this.
Mm-hmm.
And but it kind of swung the other way. And I'm
Yeah.
so excited to see you practice here over the past several years, because you've taught me so much about, so when I'm talking about minimally effective dose, I mean, maybe appropriate dose is the right word, but in relation to what could be, it's sometimes, remember that pellet dosing, you can get a surge of these hormones and then it sort of wanes over
Yeah.
time. So
Yeah.
maybe you
I
could
have
just talk
seen a
about that a little
patient.
bit.
Yeah. No, I have seen a patient with testosterone pellets who actually started noticing a little bit of voice changes. And so you do worry when you're getting females to have testosterones in these 600s, 400s, 300s. You do need to worry about and consider that there could be some virilization, meaning clitoral enlargement, voice changes, Adam's apple developing. And so I think this is something that and I've also seen people who like got terrible acne and they're kind of stuck with that until unfortunately the hormones are, out of their system. And so, I've seen patients who said it was life-changing, but I've definitely myself prefer to go the topical testosterone cream route, and that you can still get, very effective dosing, very effective improvements in quality of life. I'd actually like to share and just say a tiny bit on testosterone because it's so much thought of as, and this is in part because this is what it primarily used to be studied for, was libido. And that is from the major menopause society. They say if a female has hypoactive sexual desire disorder, low libido that bothers them, then you should consider testosterone. Many studies have shown it's very effective for helping improve sexual encounters, orgasm, everything. But it's testosterone is just like estrogen. We have receptors all over our body for it. And so it does so much more. So there's a great group out of the UK, Louise Newson, who is doing a lot of work and advocating for women's health. And so there's been 2 different large retrospective studies that they have now published. One was on 900 women, one was on 500 women, and they were already on hormone therapy with estrogen and progesterone. And they added in testosterone cream. And it was about a 4 to 6 month follow-up. 47% improvement in mood, 40% improvement in cognition, 50% improvement in libido. And then the other study, 30% improvement in energy, 35% improvement in sleep quality, 25% improvement in memory, and about 50% improvement in mood. I mean, those are some incredible benefits. And that is, again, way beyond libido, which makes sense. We have testosterone receptors throughout our entire body.
Yeah, and I think even thinking about body composition, there is a huge decrease in metabolism. I'm thinking about Herman Pontzer's work and work from John Speakman, looking at metabolism through the decades, and there's a sharp drop in the 5th or 6th decade. And I just wonder, some of those, the metabolic improvements that could happen with testosterone replacement. And I think it's not I think hormonal replacement in general, and the standard of care being so egregious, I mean, it applies to other hormones. We've talked about thyroid hormones, and this is being an issue. We've talked about testosterone in men, right? There's still a hesitation to prescribe, testosterone replacement in men because of fears of cardiac issues, and which have largely been debunked in multi-year studies, published in major journals. I think there's a lot of fear. I think there's a lot of fear over just listening to patients, right? Like, and letting them guide the treatment.
Mhm.
I mean, do you think that I'm off base here? Like, I think one of the problems that docs have is they're not in control. It's the patient in front of you who's going to report their symptoms, and you have to adjust based on what you hear, not a number on a lab, right. So I think the big problem with all of this hormone, like I'm trying to put the puzzle pieces together and describe a systemic problem here. I think the big problem is it's the docs they're not in control. Like, it is somebody else's body responding to something that's improving quality of life, and they don't know how to do that. Am I off? Like, I don't know. Just tell me I'm
No,
crazy.
I mean, I think there's a lot of truth to it. I think, in some ways, medicine is definitely getting away from the paternalistic practice of medicine, which is good, doing more shared decision making. Um, but when it comes to hormones, again, especially because a lot of the old dogma surrounding them use
I'm going to challenge you on that, right? Look at the last 5 years. Sorry. Right? Became very paternalistic, right? In the
fair.
Yeah.
Yes.
And
So
not
there's
a lot
still
of shared decision making. So,
That's true. There's still, unfortunately, a lot of paternalism going on, and I think so. When it comes to the hormones, there's some old phrases that I've literally heard in the past 2 weeks from another doc that's a friend of mine. But, well, you should use the lowest dose for the shortest duration possible. That's, again, these phrases, they do not help women. What is the lowest dose that's effective, and what does that even mean if all you're asking about is hot flashes? You're not asking about their brain fog or their mood or their all these other symptoms. You're totally missing it. Great, you fix their hot flashes, but what about the other 10 symptoms they may be having? I think I mentioned on average women have 10 symptoms during the menopausal transition.
Yeah, well, I think you nailed the head, right? Like, one, you have to be curious, right? So how do you practice? We should talk about how Toward Health practices evidence-based, hormonal treatment. One is, how does the patient feel?
Yeah.
Right? Like, first and foremost, how does the patient feel? Right? What is their quality of life? Right? This is the purpose of hormonal treatment, right? And if you're considering any hormone, and I think that there's a case to be made of all the other physiologic changes you said surrounding bone health, dementia prevention. I personally feel those shouldn't be the objective, although there could be potential good side effects, right?
Yeah, I mean, the FDA, it is approved for osteoporosis prevention. And just a couple of things about osteoporosis. So 1 out of 2 women over the age of 50 will have a fracture from osteoporosis. More women every year are hospitalized due to fractures than strokes and cardiovascular disease, heart attacks combined. And so from a prevention standpoint on osteoporosis, something I consider maybe it is worth thinking about. 1 out of 3 women over the age of 80 will have a hip fracture. When you think about the hip fracture mortality, 25% of women after a hip fracture will require to live in a long-term facility. 50% will never have the same mobility that they had pre-hip fracture. I mean, these are some terrible, scary statistics, and I'm sure everybody knows someone who's had a hip fracture, and they were just never quite the same after that. And it's really sad.
So I want to read, we have a lot of people joining in, and, here's a comment we're getting from online. I'm not going to read the whole name. Let's just say, Kathy, right? 5 years, she's chatting in. She goes, I'm 5 years post-menopause and was recently heavily discouraged from HRT because I had no vasomotor symptoms. I had brain fog, I had significant joint pain and low energy. So, I mean, this is exactly what you're describing, right? Somebody who went to their doc and was like, I have these things, and the doc wasn't able to pick it up, wasn't focusing on sort of quality of life, and was discouraged. How do you feel when you hear that?
It's so aggravating, and I feel so bad for that individual. And it's I don't want to say anything mean, but it's very sad to me, because
I don't mind
there's
saying
so
anything mean. That
there's
you were gaslit, Kathy. So
yeah, I mean,
Kathy,
it's
I
terrible.
think you were
It is really
gaslit.
terrible.
I think that you weren't. I think you deserve a little bit more time and attention, right? And I think that I think that I think there's a lot of problems in medicine that whenever anything gets in between a doc and a patient, right? So docs, we need to learn more, and I've learned so much from you, Dr. Laura, and particularly around these. And you're educating me just even here. I'm learning, and I think it's time and a
Yeah.
clear vision of what you're doing for the person in front of you.
I mean, I think it's kind of like, imagine, and this still happens commonly, and I still have patients who tell me this is what their dietitian or their endocrinologist told them. You have a new diagnosis, type 2 diabetes, you go see the doc, and they say, well, you need to have at least probably 60 grams of carbohydrates with your meal, and you need to have three 15-gram carbohydrate snacks 3 times throughout the day, so that way we make sure we're stabilizing your blood sugars. It's absolutely crazy. You are setting that person up for failure. You're setting them up for their diabetes to be chronic and progressive, which is still listed on the ADA's website as a statement. And yet we know for a fact that diabetes does not have to be chronic and progressive. You can reverse it or greatly improve it if you've been dealing with it for several decades. And to me, this is kind of similar. You go to your doc with new diagnoses or something going on, the brain fog, the all the different symptoms, and they give you the exact wrong advice. And it's really tragic that this happens, but it happens a lot. I mean, one of our patients, I felt so bad, was a 38-year-old who had gone through surgical menopause and was told that after who was put on hormones, which was great. The doctor actually put her on hormones, which anyone who goes through early menopause for any reason should be on hormones at minimum until the average age of menopause is 51, because there's a lot of great data on that improving all outcomes. But after only a couple of months on the hormones, someone mentioned the WHI breast cancer 25% increased risk, and ended up stopping those hormones, was off of them for a few years when I ended up seeing her, and had dealt with just horrific symptoms. And I mean, not to get too graphic, but this is a 38-year-old who loves her husband, wants to be, intimate with them, and it feels like daggers when they're being intimate, and they're extremely painful. And neither partner wants to be in that kind of situation. And she went and saw her doctor about it and was not encouraged to get back on the hormones, was not encouraged to start vaginal estrogen, which is, again, so effective to help. You can mitigate that symptom entirely. And just lived that way for years until coming to see us. And now, thankfully, I think he's doing really great on hormone therapy and able to enjoy her being active. And so it's really sad that, again, suffered for 3 really tough years and saw multiple doctors during that time without someone being able to review the data with her well enough to make her feel comfortable she wasn't increasing her breast cancer risk, and that it was actually beneficial to her to go back on the hormones.
Yeah, I've heard a lot of these miracle stories, and you told me one this week that really just made me pause. You gave one here of a younger patient who, had terrible sexual side effects, and wasn't really sort of needed more care. Can you give us some sort of stories that you've seen that you think are worth sharing out there about HRT that may sort of dispel myths or give people some hope? And there was one in particular this week that you told me that really moved me.
Yeah, I'll try to share 2 that really stick out to me. So one of them, and part of this too, because even I'm so grateful for what um, again, what just came out about the black box warnings, but there's still some listening to the podcast about, well, you maybe shouldn't start it over the age of 60, or just much more caution with over the age of 60. And so anyways, I want to you can still start hormone therapy after the age of 60. Honestly, there is not a limit that you cannot start hormone therapy. I think there is, again, data that you will not get these same preventative benefits if you start over the age of 60. But again, a lot of women are starting hormone therapy not for the preventative benefits. They're doing it for the symptoms that they have been dealing with and suffering with. So I had a patient in her mid 60s and more than 20 years postmenopause, actually, had not been on hormones because she had a history of breast cancer. And she was told by multiple doctors, you can't be on hormones because of your history of breast cancer. And has actually had a bilateral mastectomy. And she came to see me and said, basically, I would rather have breast cancer and die than continue to live like this. And
Wow.
I mean, like, that's an incredibly powerful thing for someone to say. And I was like, well, 100%, let's try the hormones. I don't know how much of a benefit it's going to have, but I think it can benefit you based on all of your symptoms. On the menopause rating scale, it was basically severe symptoms, some extremely severe, and then a few that were moderate. And within a few months on hormones, initially just estradiol and progesterone, significant improvement in quality of life across the board. After about 5 months, still had some symptoms ongoing. Testosterone was low. They'd also had their ovaries removed. Even post-menopause, our ovaries produce about 50% of our testosterone. So we added testosterone into the mix. And by the end of the year, it's a different person. Her husband said his wife was back, and we're talking about 20 years. So husband said the wife was back. She felt like a new person. Their relationship was renewed, and she never looking back, never going off the hormones at this point. Like, no one's going to take them from her. She will go to the grave with those hormones.
I want to ask about sort of responsible use, because I know you do this, and I know you do this with all hormones. I think, you and I both, when we're looking at all sort of hormones, like take something as simple as insulin, right? We always want to use it responsibly. Take something like GLP-1 peptide hormones, right? Thyroid hormones, testosterone, right? Like in men, there's always the potential of there's always this thought that I have, which is, let's at least cover the harms that we know, or at least suspect, right? Like, can we at least screen for things that we know around this? And there's no evidence right now that says people on a GLP-1 hormone long-term should have, calcitonin level checked or the thyroid looked at. I just think it makes sense mechanistically, and I'm sort of getting ahead of that, and I put that into my practice. In the case of men who are on testosterone replacement, I think about the prostate size, and I track the PSA. I think about the blood levels, the hemoglobin and hematocrit level, and I track those things. In the case of insulin, we monitor for really symptomatic hypoglycemia, and we want people to check. And what are the things? I know you think about this. I know you think about, okay, well, how do I do this responsibly, right? When it's a quality of life. You want to improve quality of life, right? But you also want to do no harm. And we know with any hormone, it's just the possibility of doing no harm is not there. So responsible use, I think, is one thing. And then if it's your family member, your patients, and I know you do this, how do you screen? How do you monitor? How do you approach maybe the not the fears, but there are known issues with these hormones?
Yeah, so I think certain things that I'm not necessarily screening for, but I do discuss with patients that have been shown in studies as far as increased risk, needing your gallbladder taken out, up to potentially 2 per additional 1,000 women. Now that risk is higher with the Premarin, conjugated equine synthetic estrogens. It's higher with oral estrogen. I prefer to use transdermal estradiol because it's associated with the least risk. There's no associated risk for strokes with transdermal estradiol, and some studies actually even show a decreased stroke risk with transdermal estradiol, where you do see a very slight, again, very slight, maybe 1 in 1,000 increased stroke risk, and a little bit higher with Premarin, but not much higher. And so the type of hormones is definitely, I prefer the bioidentical hormones. When you look at the comparisons of the Premarin compared to bioidentical estradiol, it increases insulin resistance, it increases inflammatory markers, it increases, again, it increases clot risk significantly more than oral estradiol. And then when you look at transdermal estradiol, again, there's zero increased risk of clot, even in people who have factor V Leiden mutations, which is extremely high risk for clotting with estrogen. But the transdermal, they have shown in studies, actually doesn't increase that risk for that population. So part of it is the formulation. Same thing with the synthetic progestins. They have many more side effects associated with them. And so bioidentical oral micronized progesterone is by far the most, I would say I exclusively use. There are some situations where I might use something off FDA, use a topical progesterone if an oral progesterone is not tolerated, but that's not very common. And the going to testosterone, because that's where I think, like you mentioned with checking PSA and other labs, for testosterone replacement, I am definitely monitoring those levels more closely, just because the potential risk, although very rare, of if you overshoot those levels way high into the men's ranges, that you could have more side effects. We have at least 4-year safety data on testosterone in women, where if you get levels even up to 95, which is higher than premenopausal ranges of testosterone for women, that there are no adverse outcomes. So that's a pretty safe number. And so, that is something that we're discussing and talking about. And then, one of the again, it's not a huge absolute risk, but I definitely like to discuss with my patients is that there is an increase in endometrial cancer risk with the micronized progesterone compared to the synthetic progestins. So classically, people say hormone therapy decreases your uterine cancer risk. And that's with the synthetic progestins. But when you look at studies using the bioidentical micronized progesterone, there's one larger study over 20,000 women, and the absolute increased risk was 0.3 per 1,000 women. So it's not huge, but it did exist. And then there was a much smaller study, only about 2,000 women, that they had a much higher baseline risk. Even the women not on hormones had almost a 6 per 1,000 risk of endometrial cancer, which is really high for a base population, and that was just being placebo. But that study showed 5 per 1,000, almost 6 per 1,000 increased risk of endometrial cancer. Again, it was a much smaller study, and the baseline risk was much higher, so there seemed to be something else going on in that population. But I think it's probably more like a 0.3 per 1,000 increased risk. So if someone is having vaginal bleeding after they, more than 6 months after they're starting their hormones, or it's really, really heavy, then we're getting a transvaginal ultrasound, likely an endometrial biopsy, working with their gynecologist to pursue that and work it up, even though, again, it's not, usually you don't find cancer, but you want to make sure you're not missing it.
I think the big, worry also for people is, am I going to get, because this is, a misconception maybe, but breast cancer is on everybody's mind, and I know how you and I both feel about screening. So, what do you do when somebody tells you, hey, what about breast cancer?
Yeah.
Am I going to get more breast cancer?
So usually I'll, initially talk about the WHI, that 25% increased risk that the news headlines came out, the press release that scared everybody. The absolute risk went from 4 out of 1,000 women to about 5 out of 1,000 women. So it's a 1 per 1,000 women increased breast cancer risk. And that was in the combined arm of the synthetic estrogen plus medroxyprogesterone acetate. What they did not mention was that if you looked at the estrogen only arm, and this is despite not being the best formulation of estrogen, they actually had a decreased risk of breast cancer and a decreased risk of mortality from breast cancer. And so the medroxyprogesterone acetate that was used in the WHI has actually now been shown in multiple other studies to increase the risk of breast cancer. Not a huge absolute number, but still has been shown several times now to do that. So the estrogen was actually protective against breast cancer. So just, again, educating people, letting them know that, and that it was the synthetic progestin that was really likely driving that risk. There's actually another really large study, I think it was out of Finland, but they looked at, it was bioidentical estradiol, and then they also had a different kind of synthetic progestin, but they had a significant decrease in mortality and breast cancer incidence in this, again, much larger study following a cohort of individuals for over close to a decade. So I think, again, it's just about education and reassuring people that you seem to be you're at a lower risk of breast cancer with hormone therapy. Definitely, you're not increasing the risk if you're using the bioidenticals. We don't have data to say that. There is no data to say that.
Yeah, I mean, this is huge news, guys. For this is absolutely huge news. This is current news. This week, HHS and FDA came out and said, "Oops, we did this wrong," and it is. It was refreshing to see that. So I wanted to spend just the last couple minutes maybe. I know both you and I have to go pretty soon and go. We have a clinic, full day full of clinic. But how did you feel to see that? Like, I know you've been passionate about this topic. I know you have reviewed the data. I know at times you and I, sometimes the depth we go in, I mean, it's complicated. We get into the weeds, and there's very few people out there who can understand that maybe you see that all of medicine has got this wrong. So how did you feel when you saw, the public health apparatus say, we messed up?
Speechless. I mean, it's incredible. I think this has probably been one of the biggest mistakes in medicine in recent times, following probably the food pyramid and our dietary recommendations that have been given to people. But I mean, this opens the doors to finally, I think, now getting people, one, open to prescribing hormones and helping women, and not, removing the fear so we can actually practice evidence-based medicine instead of fear-based medicine. But now I'm hopeful that this, again, it's going to create opportunities for more research, because we still have a lot to learn about women's hormones. And it's going to hopefully help change the medical curriculums, medical school, residency, NPs, PAs, all providers. Because, again, I was in med school less than a decade ago, and I was taught that basically the WHI and that hormones are bad. In residency, I had one lecture on menopause. And I'm grateful that my residency is actually now having me come back to our program to educate on menopause. And so I did that last year. I'm doing that again this coming year. So I think this just is going to make people feel much, much better about prescribing these things. And then also I was going to share a study that came out, and this was for vaginal estrogen, that if women went to their doctor, so real quickly on the genitourinary syndrome of menopause, which can cause so many symptoms and complications, over 70% of women deal with urinary symptoms and vaginal dryness and pain. Over 70% deal with that. Only 25% bring it up with their doctor, in part because it's a sensitive topic. Also, they think it's just natural and there's nothing to do about it. Of those 25% that actually do bring it up with their doctor, only 7% actually get treated for it.
Wow.
And yeah, it's just, incredible. And so there is a study that of those women that actually do get treated for it, 1/3 of them will not take the hormones because they read that there's a black box warning on vaginal estrogen for breast cancer and dementia, possible dementia, and cardiovascular disease and stroke. And they're like, well, I'm going to deal with my vaginal dryness. I don't want these things. And so, it's terrible. So it's been hurting women. It's been ignoring women's health for so long. And I think this is now just hopefully going to be a new era really for women's health.
I think the undertreatment with these quality of life issues, right? If you look at, I just looked up these quick stats, and I didn't verify them, but so I'll have to look into it a little bit more. But I think it corroborates sort of my judgment. If you look at women treated for hypothyroidism, right? Less than 1% have some component of T3, right? Less than 1%, which we know is, important for quality of life. We can a lot of issues, right? And if you look at men with hypogonadism, less than 30%, right? Sorry, less than 5%. This is a review from Boston University, is being treated.
Yeah.
Right.
Yeah.
So I think, when you combine these, I think it's a systemic issue. I think docs are a little afraid to let the patient lead. Right.
Yeah.
Because with all these, it's like, okay, how do you feel? How are you doing? How are your symptoms? And hopefully, there's docs out there listening to this, and, maybe Doc in the Box is there who are hearing this or conventional sort of doctors, and they see the CDC say, oops, we got it wrong. Hopefully it inspires them to go and sort of reevaluate their practice. I'll give you the last words. Anything else we got to know about HRT?
I think just, it is safe, it is effective. And if your provider has not been listening to you, and you have been, like you've said, you've been gaslit, you've been denied, you're more than 10 years postmenopause, and then there's more of that dogma that, oh, it's too late, or you keep hearing it's too late, it's too late. It is not too late. And this is like someone who was 80 years old that was able to come off of insulin with dietary changes, right? It is never too late to have an impact on your quality of life and on so much more.
Thanks, Laura. Thanks to the listeners. Thank you, everybody. We appreciate you all. And thanks for joining this live stream on the Toward Health app and on social. We appreciate you all. And thanks, awesome. I should say, thanks to, Marty Macri for really spearheading this, change at the FDA, at the level of the FDA. I think this is absolutely huge. Thank you all.
Thank you.
If you enjoy the show, please consider supporting us on Patreon by going to lowcarbmd.com.